discussion. Our case today, to know how to get this patient safe through also pre and intra and post-operative. Our patient today, 63 years man, admitted with cancer colon for hemicolectomy. Our patient diabetic on insulin, hypertensive, past history of ischemic heart disease, chronic renal impairment, and create more than 2, bronchial asthma, pulmonary hypertension on oral anticoagulant. Our patient can climb 2 flights of stairs. By this sentence, as we see that there are a lot of comorbidities in our patient. But by this sentence, patient can climb 2 flights of stairs. As we all know that physical activity is an excellent indicator of the cardiac function. So climbing more than 2 flights of stairs means a metabolic equivalent of task more than 4. So I'm not in need to ask for cardiopulmonary stress testing. So when to postpone this patient? We have to postpone any active cardiac condition, such as decompensated heart failure till 3 months of medical optimization, recent myocardial infarction less than 1 month, severe symptomatic valve lesion till correction of valve lesion, even severe asymptomatic valve lesion if no evaluation of the valve lesion within the past 1 year. Postpone till evaluate the valve lesion. Any significant arrhythmia, postpone severe pulmonary hypertension more than 40 millimeter mercury. Patient with past history of percutaneous coronary intervention, balloon angiography postpone at least for 2 weeks, because balloon angiography and manipulation on the coronaries rendering the endothelial of the vessel thrombogenic. So I have to give time for endothelialization and to fulfill the antiplatelet therapy. When patient insert bare metal stent, and this is the old type stent, not used except if can't delay the surgery, I have to postpone the patient for 4 to 6 weeks to fulfill the antiplatelet therapy. Patient insert drug-eluting stent, I should postpone any elective surgery at least 1 year to fulfill the dual antiplatelet therapy. There is a great risk of cardiac complication and thrombosis if we stop the dual antiplatelet therapy before 1 year for patient insert drug-eluting stent. So we have to carefully take history carefully, examination and investigation carefully. In immunocompromised and cancer patients, you have to search for occult heart failure, such as lower limb edema, dyspnea, or supnea, congested neck vein on auscultation rail in the chest, careless B-line on X-ray, pat wing appearance on chest X-ray for pulmonary congestion. As regard cardiac condition, as we told before, we will not need for cardiac stress testing. We can ask for ECG, echo, chest X-ray. We will ask for biomarker here as a natriuretic peptide to assess the prognosis. If these biomarkers are high from the start, so we will ask for daily serum troponin and daily ECG with oxygenation of the patient. Also, we will ask for multidisciplinary team cardiac consultation for perioperative medical optimization. When we do all of this, patient spontaneous breathing with saturation 94% on air, bilateral inspiratory and expiratory waves, fine crepitation, blood pressure within accepted range on ACE inhibitor, Concor, Proceede, and warfarin. All lab was within normal except for hematocrit and renal function. When we look at the pattern of ECG, we find this pattern: S1, Q3, T3, large S in lead 1, Q wave in lead 3, and inverted T in lead 3. This is a characteristic for pulmonary embolism. So this is a high risk patient of thromboembolic manifestation. Echo ejection fraction was 55% with mild diastolic dysfunction. Pulmonary artery pressure was 25 with mild pulmonary hypertension. So before anesthetizing the patient, I have to assess the risk first. As we all know that there is anesthesia risk factor, patient risk factor, and surgery risk factor. Anesthesia risk factor is the least impact on outcome, provide well-conducted anesthesia. I have to assess the patient risk factor and the surgery risk factor and try to modify this risk and decrease this risk. Our patient is a high-risk patient for high-risk surgery, at high risk of cardiac complication, old age, more than 4 cardiac risk predictor. Our patient hypertensive, ischemic, diabetic on insulin, chronic renal impairment. So cardiac risk is more than 15% risk or myocardial infarction within 30 days post-operative. Also at high risk of venous thromboembolism, old age, cancer patient undergoing prolonged surgery more than 60 minutes, pelvic surgery, cancer, all these lead to, and the ECG pattern. At high risk also of ARDS and transfusion-related acute lung injuries. Old age, major fluid shift, blood and blood product. I will use blood and blood product in this patient. Also, our patient at high risk of sepsis, old age, immunocompromised, diabetic patient. As a risk of acute kidney injuries, this is very evident in our patients. So careful handling fluid and drugs with this patient. As our patient, old age, diabetic, hypertensive, major trauma, all these interfere with renal autoregulation. Also, our patient at high risk of post-operative cognitive dysfunction. They found that old age, when they interrupt their daily activity and the atmosphere of hospital admission with multi-drug administration, they easily go through cognitive dysfunction. We have, after we know the risk, we have to decrease this risk. To decrease the risk of thromboembolism, we have to stop warfarin for 4 to 5 days and ask for daily prostaglandin activity and INR. Till INR become less than 2, we will start bridging for intravenous heparin, because this is a high-risk patient with chronic renal impairment. We can't use low molecular with heparin. We will use intravenous unfractionated heparin for 2 or 3 days preoperative till INR become 1.5, and this is the least accepted level of INR for elective surgery. Then we have to stop heparin 6 hours preoperative, provide that PTT is normal, and be careful, patient taking heparin for more than 3 or 4 days, you have to check platelet count for fear of heparin-induced thrombocytopenia. Also, to decrease the risk of thromboembolism, we can use pneumatic leg compression. These are pneumatic device which compress the lower limb at pressure 35 to 40 millimeter mercury, 10 seconds every 1 minute. This promotes the venous return and compression of blood vessel in the lower limb. Avoid prolonged immobilization. This patient is a pulmonary hypertension patient with chronic hypoxemia lead to polycythemia. So if hematocrit was more than 60, we can do phlebotomy and replace this with intravenous fluid. To reduce the risk of acute post-operative acute kidney injury, we have to optimize perfusion. If volume overload was more than 5%, consider using diuretics. If more than 10%, consider using renal replacement therapy. Also, stop nephrotoxic drug used empirical and seek for alternative. Even adjust medication dose for renal clearance. Glycemic control, keep your blood glucose level 110 to 180 milligram per deciliter. There is no tight glycemic control show no benefit. Only tight glycemic control restricted to certain cases such as severe traumatic brain injury, severe sepsis, is of no benefit anymore. Only maintain your blood glucose level between 110 and 180. Avoid any radio contrast. Avoid post-operative non-steroidal anti-inflammatory drug. To avoid post-operative sepsis, you have to give antibiotic prophylaxis 60 minutes pre-operative, maintain hypothermia, hyperglycemia, maintain perfusion, early recognition of sepsis and organ dysfunction. Any unexplained organ dysfunction should be considered sepsis until proved otherwise. To decrease the post-operative risk of ARDS, use protective lung strategies, intra and post-operative, low tidal volume, high respiratory rate, PEEP, plateau pressure less than 30, permissive hypercarbia. Also, early diagnosis and treatment of sepsis. Avoid volume overload during resuscitation. Once I am out of shock, keep on 5 to 10 negative fluid balance. You can use restrictive blood transfusion policy to avoid transfusion-related acute lung injury, but be aware of over-restriction, which lead to hypovolemia and hypotension. Now, what is the anesthetic plan? What is my plan of anesthetic technique? I should tailor an anesthetic technique especially designed for every patient. There is no technique superior than another, but there is a physiology. You have to not to alter the physiology by any way. If you understand the physiology and the associated comorbidities and the physiology of this disease, you will know how to anesthetize your patient by making an anesthetic technique especially designed for every patient. So our plan was to give balanced general anesthesia combined with epidural analgesia to get the benefit of epidural intra and post-operative analgesia. Also, epidural can modulate the hypercoagulable state with and decrease the need for intraoperative drugs with general anesthesia. And combine this with balanced general anesthesia, because patient old age, cardiac, maybe orthopneic dyspneic, he will never lie flat or supine for long periods. So you have to use balanced general anesthesia with epidural analgesia. Is there any alternative? Yes, there is a general anesthesia, narcotic based only. We have to use also multimodal analgesia, not only one route of analgesia. Multimodal analgesia, you can use sonar guided nerve block for post-operative analgesia. So I have to go and anesthetize my patient. No, please don't rush, as we mentioned before. Counseling the patient is very important. You have to respect the patient autonomy. Patient have the right to share in decision making in anything concerning them. The patient and his relative should understand the risk and the advantage of the proposed anesthetic technique and the potential risk of the technique, the risk of epidural alone should be explained. If patient refuse or her caregiver refuse, you should offer an alternative. And don't leave your patient panic by the risk that you just mentioned out or telling him. You have to reassure your patient by awareness of the preventive measures that will modify these risks. They found that when we counseling patient by number, they understand the risk more than, or rather than telling them this risk in words. For example, if we telling our patient you are at moderate risk of so and high risk of so, they didn't get the risk well. Rather than telling them if there is a 100 case will go through the same operations that you will have, and they have the same comorbidities and the same disease that you have, 20 of them will have this risk, and the other 90 will go safe without any complication. They found that patient understands the risk more when in number rather than words. So after counseling the patient, I have to take high risk consent, prepare for ICU bed, prepare for possibility of renal replacement therapy, prepare blood and blood product, and preoperative medical optimization is a must. This is a mandatory. Patient on beta blocker, you have to continue beta blocker for them. Don't stop beta blocker. As regard beta blocker guideline, don't stop beta blocker for patient already on beta blocker. Don't start beta blocker one day preoperative. Don't start beta blocker at high doses without titration. Don't start beta blocker for low risk patient for low risk surgery. Start beta blocker for high risk patient for high risk surgery at least 1 week preoperative with titration. As regard ACE inhibitor and diuretics, if we are using this drug for only hypertension, you can stop this drug for the half-life of the drug. But here, patient taking it for hypertension and cardiac condition. So you have to continue ACE inhibitor and diuretics And consider using of invasive monitoring intraoperative for fear of hypotension with anesthetic drug, and use invasive monitoring. As regards the statins, as we all know that myocardial infarction is 50% because imbalance between oxygen demand and oxygen supply, and the other 50 because rupture of atheromatous plaque. And here is the role of statin. Statin stabilize the atheromatous plaque and prevent their rupture. Nitroglycerin and digital should be continue, and be careful. Patient on digitals, you have to check for serum potassium. It should be more than 3.5 preoperative. And also, of course, stop heparin 6 hour preoperative, as we mentioned. Consider fasting hour and 2, 4, 6, 8 rules, as we all know. But be careful of something. I want to tell you a little thing. In trauma patient or severe trauma patient, fasting hour, you will calculate the fasting hour from the time of last oral intake till the time of trauma, because at the time of trauma there is severe delay in gastric empty or even stoppage of gastric empty. So you have to calculate the fasting hour from last oral intake till the time of the trauma. Okay, monitoring of the patient. Our patient is high-risk patient for high-risk surgery. So beside the standard monitoring, we have to use invasive monitoring using arterial line for beat-to-beat blood pressure, cardiac output monitoring using transesophageal echo or central venous pressure. Pre-medication is very important to alleviate the stress of the patient. But be aware of over sedation in old age. You can use opioid, midazolam, xylocaine 2 minutes before intubation. Even you can use it topical spray on the larynx, intra-cuff, as you can put it intra-cuff. Use beta blocker, dexamethasone. The most important is the least laryngoscopic time, less than 50 seconds. Use glycopyrrolate better than atropine. You can use stress ulcer prophylaxis, DVT prophylaxis, antibiotic prophylaxis 60-minute preoperative, as we mentioned before. Then insert your epidural cast using diluted local anesthetic. Before anesthetizing our patient and intubate our patient or giving any intravenous anesthetic, pre-oxygenation is a mandatory. Pre-oxygenation for 3 minutes. This is a buying time technique. You buy time for yourself and for your patient. In case of apnea occur, you have 8 minutes pre-oxygenation for 3 minutes, give you save apnea time for 8 minutes to deal and go through and try to find a solution for this hypoxia before any symptom or severe symptom occur. So this is a buying time technique. You have to mandatory pre-oxygenate for 3 minutes. And then start induction using opioid. You also, in old age, you have to respect the time for arm brain circulation. Okay, give your medication slowly with meticulous de-aeration. Giving opioids, you can use fentanyl or remifentanil. Sleeping dose of anesthetic as etomidate or propofol. We can use muscle relaxant as ismiron if we need for rapid sequence induction. Then intubate your patient, or we can use supraglottic device if we are fear of stress of intubation. Intraoperative, we can use mechanical ventilation using protective lung strategy, as we mentioned. Maintenance if ejection fraction less than 50, use narcotic-based anesthesia. If more than 50, we can use narcotic beside make awake of volatile as SIVO or ISO. Our aim intraoperative, as we said before, don't interrupt the physiology. Our aim is to maintain sinus rhythm, maintain preload, afterload, maintain contractility, make your patient pain-free, keep your hemoglobin more than 9 grams per deciliter, avoid any event lead to decrease in systemic vascular resistance, especially in pulmonary hypertension patients such as deep anesthesia, vasodilator, spinal hypovolemia. Avoid any increase in pulmonary vascular resistance, such as hypoxia, hypercarbia, acidosis, pain, intermittent positive pressure ventilation with high tidal volume, using of nitric oxide. All this should be avoided. As regard the fluid, maintain adequate tissue perfusion. If there is a massive blood loss, so it is advisable to use low volume, less than 1.5 liter crystalloid, then shift to higher plasma and platelet ratio. This early in resuscitation were associated with decreased mortality. Our target in resuscitation in massive blood pressure, a massive blood loss, is to maintain the mean arterial pressure around 60 and the systolic around 80 to 100 millimeter mercury. In hypertension, try to keep higher mean arterial blood pressure. Keep your hemoglobin between 7 to 9 gram per deciliter, INR less than 1.5, platelet count more than 50, and in severe traumatic brain injury or vascular surgery, keep your platelet more than 100,000. Keep your pH within normal, 7.35 to 7.45. Keep your core temperature more than 35. Use warm intravenous fluid. Keep your base deficit less than 3 and serum lactate less than 2. What if intraoperative or adverse event occur? Please don't do like him. We are an anesthesiologist. We have a solution for everything. Okay, what if hypotension? As we said before, hypotension need explanation. First, search for the cause and treat it. If deep anesthesia, decrease the depth of anesthesia. If hypovolemic, replace fluid guided by central venous pressure and transesophageal echo. If there is a beep or auto beep, decrease beep. Then consider using vasopressors as phenylephrine, because this don't make tachycardia. Ephedrine can be used in a smallest possible dose and incremental, because ephedrine show unpredicted response with hypertension. So better to use phenylephrine. If hypertension, also treat the cause. If pain, give opioid. If hypercarbia, you can increase the respiratory rate. If light anesthesia, increase the depth of anesthesia. Always search for full bladder and check for urinary bladder kink or obstruction in anesthetized patient. If hypoxia, treat hypoxia, then give medication. You can use esmolol, propranolol, calcium channel blocker, nitroglycerin intravenous, or even a patch. You can use sodium nitroprusside intravenous infusion. If intraoperative ischemia, you can use acute coronary syndrome protocol. If ST segment elevation MI, you consider BCI. Then normalize your heart rate and treat pulmonary edema. If blood pressure is maintained, consider use diuretics and nitroglycerin. If hypotension, use enodilator. If there is a volume overload or acute renal failure, consider renal replacement therapy, as we mentioned before, as continuous venous hemofiltration. If bronchospasm occur intraoperative, rule out mechanical causes first, as blocked endotracheal tube, circuit anaphylaxis, increase the depth, FiO2 to 100%, deep plan of anesthesia. Ask the surgeon to stop surgery if there is a hypoxia or hypotension. Reduce the respiratory rate. If there is an auto PEEP, you can use salbutamol inhalational into the circuit, 6 to 8 puffs. You can use salbutamol intravenous or cyphilin intravenous, magnesium sulfate, adrenaline nebulizer to treat the bronchospasm. What will happen at the end of surgery? What do you think? Should you extubate your patient and let your patient suffer from all these risk of surgery and all these hemodynamics that changes? No, it's not advisable. It's advisable to continue mechanical ventilation, transfer your patient to surgical ICU for stabilization of oxygenation, maintain perfusion, maintain normothermia, maintain normoglycemia, optimum post-operative analgesia, ask for daily troponin and ECG, as we mentioned before, if biomarker was high from the start, allowing time for recovery from injury. Give your patient at least 48 hours to modify risk of sepsis, acute ARDS, and acute kidney injury. If you do all of these measures, so you will be able to tell your hand, don't worry, you are in a safe hands. And